Monoclonal antibody reactions can be broken down into immediate reactions and delayed reactions. Immediate reactions include both anaphylactoid and anaphylactic reactions. Anaphylactoid and anaphylactic reactions may present identically and are treated identically, but the underlying pathophysiology is quite different. Anaphylactic reactions are true type 1 hypersensitivity or allergic reactions mediated by IgE. Anaphylactic reactions can involve airway obstruction or vascular collapse that can become rapidly progressive and potentially fatal. Anaphylactoid reactions represent the majority of infusion reactions. Anaphylactoid reactions involve partial hypersensitivity, are not IgE mediated, and are generally less life-threatening than anaphylactic reactions. Both anaphylactic and anaphylactoid reactions can occur during or immediately following monoclonal antibody administration. The National Cancer Institute's Common Toxicity Criteria, a standardized tool for reporting side effects in patients receiving investigational therapies, defines both anaphylactoid reactions and anaphylactic reactions. The cytokine release syndrome and severe infusion reaction grading tool correlates to non-IgE mediated anaphylactoid infusion reactions. Grade 1 reactions are mild and do not require infusion interruption or other intervention. Grade 2 reactions require intervention and respond rapidly to intervention. Grade 3 reactions do not rapidly respond to intervention, recur after initial improvement, or require hospitalization for clinical management or monitoring. Grade 4 reactions are truly life-threatening, requiring intubation with ventilatory support or vasopressors. Grade 5 reaction is death due to infusion reaction. Anaphylactic reactions are also defined by the National Cancer Institute's Common Toxicity Criteria and are termed allergic reactions or hypersensitivity reactions. Grade 1 reactions are mild and include transient flushing or rash and a low-grade fever. Grade 2 reactions involve fever, dyspnea, rash, flushing, and urticaria. Grade 3 reactions are more severe and involve symptomatic bronchospasm, hypotension, edema, angioedema, and the need for parenteral medications. Grade 4 reactions are full anaphylaxis, and grade 5 reactions are those which result in death due to anaphylactic infusion reaction. Delayed infusion reactions are those which occur 24 hours or more after monoclonal antibody administration. Delayed infusion reactions are much less common than immediate infusion reactions. Monoclonal antibody infusion reactions and true allergic reactions vary in severity, ranging from mild to life-threatening. Fortunately, monoclonal antibody infusion and true allergic reactions are rarely fatal. The most common infusion and allergic reaction signs and symptoms include fever, chills, rigors, rash, pruritus, nausea, arthralgias, myalgias, hypotension or hypertension, bronchospasm, cough, dyspnea, tachycardia, and tumor pain. To date, there are no reliable methods to identify which patients will experience infusion-related events. Multiple antibiotic sensitivities, concomitant use of beta blockers or ACE inhibitors, history of allergies, female gender, and comorbidities are possible risk factors for infusion reactions. It is important for oncology nurses to have a historical understanding of all patients receiving monoclonal antibody therapy, with particular focus on the potentially high-risk features described in the previous slide. It is also imperative to have written policies or protocols for managing infusion reactions, both anaphylactic and anaphylactoid. Swiftly initiating appropriate pharmacologic and non-pharmacologic measures will maximize patient safety. Written policies should reflect the up-to-date management standards for the administration of monoclonal antibodies, as well as for treating infusion reactions. Additional recommended written policies include those for antibody-specific pre-medications, IV fluid, and monitoring, drug-specific management of mild to severe infusion reactions, as well as for anaphylaxis management. Oncology nurses play a primary role in preparing patients and families for monoclonal antibody therapy. Patients require education on expected side effects and the importance of immediately reporting side effects. The potential reactions with any monoclonal antibody are often overwhelming to patients and families. Reassurance that most monoclonal antibodies are well tolerated with only mild side effects, as well as reassurance that your practice is well prepared to handle any side effects, provides emotional comfort to patients and families. It is also important to provide the patient with instructions for after-hours infusion reactions at home. Prior to initiating any dose of monoclonal antibody, a complete assessment, including vital signs, hydration status, oxygen saturation, heart and lung sounds, skin assessment, and edema assessment to establish a comprehensive baseline is recommended. Appropriate laboratory testing prior to initiating monoclonal antibodies may include a complete blood count with differential, prothrombin time, partial thromboplastin time, electrolytes, liver and kidney function, and a thyroid panel. Once baseline is established, administer drug-specific pre-medications as applicable. Pre-medications, if appropriate, are administered in attempt to reduce infusion reactions. Pre-medications commonly include acetaminophen and/or diphenhydramine. Most monoclonal antibody infusion reactions occur at a higher frequency and at a higher severity during and after the initial administration. Therefore, many monoclonal antibodies utilize unique administration schedules where less drug is given initially and/or drug is given over a longer period of time initially in attempt to reduce infusion reactions. In general, most monoclonal antibody infusion reactions are managed similarly. Most drug-specific administration guidelines recommend decreasing the rate of the infusion, usually by 50%, for mild to moderate infusion reactions, and stopping the infusion for severe infusion reactions. A patent IV line with normal saline should be maintained. Never leave a patient unattended during an infusion reaction. Obtain vital signs and oxygen saturation as soon as possible. In general, unstable patients should have vital signs and oxygen saturations repeated every 2 minutes until stable. Once parameters are stable, they should be repeated every 5 minutes for a minimum of 30 minutes. Once stabilization is achieved, signs and symptoms may return after the supportive care drugs initially administered wear off. Careful attention should be paid to the cardiopulmonary system, since severe cardiac or pulmonary compromise may be fatal. Refer to written policies or protocols for appropriate practice-approved pharmacologic and non-pharmacologic interventions. Commonly utilized medications for the treatment of side effects are antihistamines, including H1 blockers, most commonly diphenhydramine, and H2 blockers. Acetaminophen may be used to treat pain or fever associated with infusion reactions. Aminophylline may be used to treat bronchospasm. Steroids may be appropriate as pre-medication in patients at high risk of or with prior history of significant infusion reactions, as well as for real-time management of infusion events. There are multiple options in this class, and steroids may be repeated every 6 hours as appropriate. Patients experiencing anaphylaxis or severe infusion reaction may require inpatient hospitalization for further management and/or monitoring. Epinephrine and dopamine are used to treat severe events, epinephrine for anaphylaxis and dopamine for cardiovascular collapse. It is critical to document all interventions and the patient's response to each intervention. This not only assures good compliance with documentation standards, but also allows for comprehensive planning for future doses. If the infusion is restarted, monitor vital signs and oxygen saturations every 15 minutes for the remainder of the infusion, and consider additional monitoring for 1 hour after the completion of the infusion. Again, monitor for the return of signs and symptoms as any initially administered supportive care medications are cleared. Immunogenicity describes an immune response with antibody formation against a foreign antigen. In the setting of monoclonal antibodies, immunogenicity refers to a patient's immune system producing antibody against the foreign portion of a monoclonal antibody. When exposed to murine antibody, the immune system may produce human anti-mouse antibody, or HAMA. When exposed to chimeric antibodies, the immune system may produce human anti-chimeric antibody, or HACA. An immune response against human or humanized antibodies may produce human anti-human antibody, or HAHA. Typically, the more foreign the antibody, the higher the incidence of immunogenicity. In the setting of conjugated monoclonal antibodies, the immune system may produce antibody against the toxin attached to the monoclonal antibody, which is called human antitoxin antibody, or HATA. Infusion reactions, including anaphylactoid and anaphylactic and delayed reactions, are common side effects of monoclonal antibody therapy. Although infusion reactions can be extremely frightening and unpleasant for patients, fortunately, most recover without long-term consequence. Oncology nurses are the heart of early recognition and prompt intervention once infusion reactions occur. It is of the utmost importance that oncology nurses have a good basic understanding of the pathophysiology behind infusion reactions in order to maximize patient safety. This is done through patient education, appropriate monitoring during monoclonal antibody administration, and prompt intervention once infusion reaction is noted. In addition, oncology nurses are in a unique position to influence the establishment of and development of written policies or protocols on administering monoclonal antibodies and managing infusion reactions.
Thank you. Please stand by.